Donc, j'inviterai le docteur Hollett puis le docteur Logart pour une table de discussion. Cette fois-ci, il va y avoir moins de présentations. Jonathan, come with us. Une discussion sur l'insuffisance cardiaque. On va essayer de voir c'est quoi les différences. Je ne parlerai pas beaucoup de la situation au Québec puisque vous la connaissez très, très bien. Ce que je voulais, c'est qu'on regarde un peu, qu'on découvre les particularités du reste du Canada et de la France.
It's my pleasure to speak to you today. This is the second time I've been asked. The last time I was here, I believe, was in 2007, and I discussed some of our regional initiatives in Nova Scotia. And I thought that I was getting up too early in the morning in Nova Scotia, so I moved west, and I get 3 extra hours of sleep every morning. As a result of that, the bad news is when you come here, you sometimes oversleep, like this morning. What I wish to talk to you today is to give you a Canadian perspective of heart failure, especially in terms of the amount of effort required to care for this large group of very sick patients, outlining some of the challenges that we face, and would suggest to you that we try to face them together and to learn from each other, one side of the country to another, as well as internationally. This is the reality of today. We have initiatives to reduce SALT, which are voluntary, which we know will face challenges. We have lots of video games. We have lots of internet. Some of you are probably on the internet right now. And as a result of that, we have less physical activity. We have increased caloric intake and hypertension, which is the #1 precursor to heart failure worldwide, and especially in the Western world. You say, well, we have better therapies for acute MI, and that is true. We have better revascularization and medical therapies to prevent the development of heart failure. In fact, it delays the onset of heart failure because patients live longer, and they have an increased capability, therefore, of developing heart failure at a later date. This study was from Alberta, published by Justin Ezekowitz and colleagues. And what they did is they looked over a 10-year horizon in Alberta, all patients who presented with acute MI. And we know that patients who do suffer acute MI will either die or they don't die. And if they do die, they will go on to develop further cardiovascular events down the road. This was a study that reviewed elderly patients with heart failure over the age of 65. And you can see that what happens is that while the mortality in hospital goes down, the actual development of heart failure over the long term goes up. And so for patients that we treat with cardiovascular disease and heart failure in particular, even though we have studies upon studies showing improved mortality, there was one reported just a couple of months ago, in fact earlier this month, with yet another medical therapy that may improve outcomes, you can see here that in the long haul, they always come back. And so you say, well, we're doing a good job with heart failure in Canada, but remember that we have more patients coming into the queue, and that number continues to rise. So the overall prevalence of heart failure, even though it looks like we've really managed to stop the increase in mortality and hold the fort, as it were, when you look at it at the end of the day, it's at an increased cost, and it isn't always what you think it was. I got this nasty surprise about a month ago, and it stayed with me for about a day. Don't forget that heart failure is no longer diagnosed only in the hospital. Again, a 10-year horizon of heart failure diagnosis in the province of Alberta, a fairly robust data gathering system in that province. And as a result, we were able to look at new diagnosis of heart failure and where it occurred. And you can see that over trends, it is less frequently diagnosed in the hospital, more frequently diagnosed as an outpatient. Once they develop the diagnosis of heart failure, they have a similar amount of hospitalization, although if they are diagnosed with heart failure, they are less likely to die in the short term. What does this mean? It means that even though the job that we're doing is improving, the burden of heart failure becomes greater over time. So this problem is not going to go away. Now, I know I'm preaching to the converted here, but it's the size of the problem that I wanted to get to you. Now, this is a CCORT atlas, CCORT. It is a surveillance tool. These maps can be downloaded online, by the way, if you want to, www.ccourt.ca. And this is an atlas. It's several years old now, so these numbers are no longer accurate, but it was a good snapshot of a few years ago. You can see that according to this map, there is large, and I mean very large, variation in terms of outcomes. And you can see that in Quebec, it's actually pretty good compared to the rest of the country. Look out west, it's disastrous out there. I'm not sure if it has anything to do with sleeping in, but there's a real problem. You can see readmission rates are higher. If you fast forward to our own hospital, you can see that out of 3,500 discharges in 1 year in the greater Calgary area, which is a lot of heart failure discharges, you can see that our rate at 30 days is quite high. We pride ourselves on having a low acute MI rate, but in terms of overall disease burden, this disease burden is greater, and it is a great challenge that we've focused a lot of our efforts on in the past 2 years. One of the problems is having an expert involved in the care. Now, I don't mean the only person taking care of these patients, but having someone with expertise to review the patients. You can see that in the city of Calgary, which we consider to be a large Canadian city of over 1 million people now, less than half of the patients, when they're in hospital and with heart failure, ever have any contact with a cardiologist. Now, the practice pattern where we are is that internal medicine does not see very much heart failure, only 10 to 15% of it. That leaves about half of the heart failure patients who are cared for either by someone like surgeons or other specialties, and surgeons usually not that interested in heart failure, or hospitalists, which are generalists or family doctors who are contracted to take care of inpatients. So there's a problem with how often we see. Is that just in Calgary? No, it's across the country. Now, once again, if you look in the southern portions of Quebec, Quebec has a fairly high rate of specialist involvement in heart failure care. It's almost certainly higher now because this map was constructed just about when the heart failure clinic explosion occurred in Quebec. You'll recognize the timing of that. So that would be Quebec would be a darker province now on this map. But the rest of Canada isn't much darker than it is right now. And as I said this morning, I heard some murmuring in the audience when I said around 8% at best. That's not I didn't make that number up. It's definitely 10% or lower in most parts of the country. Well, I apologize, this slide has not been updated. There's about, I think, 1,200 or 1,300 cardiologists now in Canada. Not 8,000. I heard that number last night. Wow, 8,000. That's a lot of cardiologists. In Canada, we have about 30,000 general practitioners, another 25,000 specialists. If we had a conservative estimate of 300 to 400,000 heart failure patients in this country, which we think we do, then that comes out to 406 heart failure patients per doctor. Now, there aren't very many doctors who can take care of 406 heart failure patients while they're expecting twins, but I think there's at least one in the audience here. But apart from those kinds of energetic individuals, very difficult, and we understand now that the numbers mandate that we do this in some fashion in collaboration with primary care or family doctor offices. Exactly how that is going to be implemented across the country will almost certainly vary according to the region, and there will be differences in how that takes place all the way from Vancouver to Halifax and St. John's and in between. So what should we look like? Well, we can take some lessons from other areas. Now, I specifically will not comment on the very well-developed heart failure networks in France, and as well the heart failure networks in Quebec, which is definitely advanced beyond what we have in the rest of Canada right now. But I will focus on what's happened in some American sites just for learning purposes, and where we can go, where we think we're going to go. Has anybody ever read this report? No? It's only 400 pages long, so it shouldn't take you very long to read. This is a report to Congress from the National Institute of Health in collaboration with CMS, which is the payment arm of the healthcare system in the U.S. for public payers. They've recognized a big problem with heart failure for a very long time. They're estimating 5 million hospitalizations for heart failure annually in the U.S., 3 to 5 million per year. And they said, why don't we set up our Medicare networks to provide better disease management, almost as good as heart failure clinics? Okay, so then they threw $70 million. I said, here's $70 million. And they chose several different Medicare or contracting agencies to provide care, and they just gave them money and they said, do what you want to do, but we want you to measure outcomes in chronic diseases, especially heart failure. So every one of these did a different intervention. None of them collaborated with each other. They implemented what they thought would work. Some of them were inner city setups. Others were rural. Others were in very affluent neighborhoods. Everything in between, all 8 of them, in different parts of the country. And you can see here, I'm not going to show you all of the data and slides, but you can see here that if you look at one of their primary outcomes was mortality, another one was rehospitalization, another was patient compliance, another was patient knowledge, and another one was cost. And I'm showing you the mortality slide because that's what people like to see the most, and I think you'll agree with me, this is a very unimpressive result for $70 million. And indeed, they failed to show a single improvement in any consistent improvement in any of those outcomes. 1 or 2 of those outcomes were positively impacted by 1 or 2 of these interventions. And they found several key learnings, which I will not read to you. Just go to the bottom one if you like. That's the most important one. They did not save lives, they did not prevent hospitalizations, and they ended up spending more money. What's the learning for me? The learning for me in this is to simply throw money at a problem is not the answer. There needs to be a plan constructed from the grassroots, from individuals like yourself and like us, and like in a collaboration with government in order to have a coherent system that will work together and that will be able to measure improvements. I'm sorry about the slide. That does not show up very well. I'll skip that one. What should we measure? There are several measurement agencies that have been developed worldwide. Almost all of them measure only hospital discharge activities, such as beta blockers, ICDs. They do not measure much in the community. There is very little data worldwide, Canada included, for outpatient heart failure therapy. There's a bit of data where we look at heart failure clinics, and I'll get to that in a minute, but for the real world with family doctors, almost nothing. So we have only a small snapshot of what happens to a patient when they go home from the hospital. The average heart failure patient spends 1% of their life inside a hospital and 99% of their life outside of a hospital. So it would make sense to measure outcomes during the part of heart failure where they spend most of their time, because just maybe what happens to them as an outpatient has an impact on whether or not they go back to hospital and what happens to them in there. And so what we've developed in this year's heart failure guidelines is a set of potential performance indicators, things that we want to measure that outline good care.